musculoskeletal check sheet. Things that we're going to start with. The patient's going to start in the seated position, and basically we're going to inspect, and then inspect is with our eyes, and palpate means we're touching something. So the very first thing is the range of motion of the TM, well, inspect, palpate, and range of motion of the TMJ. So basically, I'm looking both sides for any abnormalities, any symmetry. And we'll see, are you chewing gum? Are you?
No,
Oh my gosh!
I didn't swallow it. It's
Okay.
I won't chew it.
Okay, good. So,
Stand up for it.
yeah. So my hands are freezing, so I apologize. So basically, I want to put my hands right here. So open your mouth and move your jaw side to side. Ooh, felt a little grinding there, and chin forward. Okay. And so if there's no, again, I could feel some grinding and everything like that. But did that hurt you at all? Any problems with that? So if it's asymptomatic, we're not going to spend too much time. We're not going to worry about it. The shoulders. So let's see if we can go ahead and have you just rub down just so we can get to your bony landmarks. So the things that we're looking for is, and I'll do it here and then we'll kind of do it over here. So suprasternal notch, really important to find that. You can find that in everybody. You're going to walk your fingers out the clavicle like this, okay? It's going to dive in, and then when it starts to come back out, you'll feel that little depression. That's our AC joint. We're going to drop down and go medial. We're going to feel the coracoid. And then usually what I like to do is I like to put their arm in this position, and I don't know how well our skeleton's going to, external and internal rotation. So this is, you can kind of see external rotation, internal rotation. I'm going to do that while I'm holding here, kind of feeling for those bumps. And I can try to feel the bumps as they go between my hand, and you can sort of feel the two bumps and the groove in between, and you can actually even palpate that biceps tendon. Okay, so those are all the things that we're doing. So let's do that over here. So again, sorry about this. So here's our suprasternal notch. Here's our clavicle. I'm going to walk my way out, pressing pretty firm. Okay, when I get right out here, really great AC joint right there. So I can feel the bone here and the bone here, and there's a depression. If I slide down and go medial and press kind of firmly, and if folks hurts a little bit, sorry about that. So he's pretty muscular, so I have to press a little bit, but skinnier folks, you'll be able to feel that just poking out, okay? Next thing I'm going to do is I'm just going to move your arm back and forth, so I'm isolating, and here's his biceps tendon groove right in there. This is a greater and lesser. There's the groove right in there, and I'm boinging right on his biceps tendon. You can feel me kind of compressing on that. Those are the landmarks. They're really important not to just say, I'm palpating the shoulder. Okay, well, no, you really didn't. It's important to have specific things that you're actually doing. So I'll let you go ahead and you can put your gown back on. Elbow, we've got the medial and lateral epicondyle and the olecranon, so let's go ahead and look at that. If I can, and we would do this obviously bilaterally, go one side and then the other. So if we go ahead and compress up, we can see the lateral epicondyle here, medial epicondyle, and the olecranon. Olecranon's part of the ulna, and these two are part of the humerus. And if you're not convinced, come over and look at your skeleton, just see, oh yeah, that's really true. It's always good to go here and then go here. And of course we do that on both sides, okay? The next one is going to be the wrist. We're going to do the anterior posterior joint line, the medial lateral joint line. So anterior posterior joint line just means if I were to move the wrist up and down here, I can kind of feel bone, I can feel first of all, you can see the styloid. Here's the ulnar styloid, the radial styloid, and then right in here is all the carpal bones. There's a little soft spot, so I feel bone, and then I feel bone, and there's a little soft spot. That is the anterior posterior joint line. If I needed to put a needle in there, I'd know where to go. You want to try to aim for not hitting bone, but getting the joint space. The medial lateral joint space, if I wiggle the wrist back and forth like this, if you find these styloids right in here, that's the joint space. And really what you're trying to do is just compress here and compress here. You're trying to determine if it feels swollen, for instance, if there's fluid within it or something like that. And again, we're inspecting, we're looking, comparing one side to the other to make sure we're not noticing anything. The snuff box, so let's go ahead and have you bring your thumb up like you're hitchhiking. So he's got a great snuff box. Everybody look at that snuff box. Can you see that? Look at that snuff box. We'll talk about the different tendons that are actually making the snuff box. But basically, I'm just going to press in the snuff box. Does that hurt? Do you have any problems with that? And that's where the scaphoid bone is, and we'll talk about the significance of that in anatomy. So next, we're going to look at the MCPs. We're going to compress the metacarpal heads. We'll have make you make a fist. So basically, if I can have you do this with your hands, and you can kind of see, remember we said the knuckle was part of this bone here. So if I needed to get into a joint, I would actually feel right here. That's the dorsal groove, there, and there. And you can do that on yourself. You kind of feel bone, and there's like a little depression. If I needed to get into that joint, to, like with a needle or something, that's where I would go. I wouldn't be sticking up here because there's no joint space over here. But the idea is you're just trying to feel, does it feel boggy? Does it feel swollen? Do I see any thickening? Kind of like, you know, that patient that we saw a little while ago had all that thickening that didn't have knuckle prominences quite like that. The next things, let's see. Okay, now every single PIP and DIP. So you're going to have the patient have their hands out like this. So if you think about it, I need to go lateral and AP for every joint. Lateral, okay, every one. Does this hurt? Does that hurt? And, you know, basically, and you can do several of these, you know, kind of simultaneously. You know, it's better if you kind of do one at a time and then compare back and forth. But the idea is you're compressing each one and you're looking at it. Does this look like a Heberden's node, a Bouchard's node? Is it thickened? Is there that fusiform swelling? All that kind of stuff. But when you're doing your exams, I want you to, every single joint in the hand, you should be going in the anterior posterior plane and the lateral plane. So the next thing we're going to jump down is the lower extremity. So the knee, and it's always good to sit down when you're in your exam room, so don't try to lean over. I've actually seen some students in OSCE exams get down on their knees on the ground. I'm like, you got a stool right there, sit on the stool. So look for your stool. It is important in the beginning to stand, and sorry I'm blocking you just a little bit, compare from one side to the next. So with regard to the knee, so we'll start kind of over here. As far as bony prominences, and it doesn't matter exactly what order you do, but you want to have a system. You want to be feeling the condyles, so I want to feel this condyle, I want to feel this condyle of the femur. You want to feel the tibial condyle, so this is kind of like the tibial plateau. You're going to feel sort of this region as well as this region. You're going to find the joint space, that natural place where it's in between, that soft spot. And again, you're looking at it to see if it looks, most people kind of have like a little hollowing out. You can actually see his patella, you can see his tibial tuberosity, you can see the patellar tendon. I know his joint line is exactly like right there, and I would be comparing, but if it had swelling, you might not see that normal depression. It might be pooched out a little bit. So that's the idea of what you're trying to feel when I say the joint line. And within that joint line, we know our meniscus are in there, and also we know our LCL is right here, and our MCL is right here. So you can kind of be palpating. If somebody said, I hurt right there, that's a big clue. That's probably MCL. It could be some other things. So basically, we're going to start here, do that, do this, patella, tibial tuberosity. So all those things, we want to do that. So the first thing, we just kind of, again, compare both sides. I like to start at the joint line, so I like to start right here, kind of palpate that. At some point, I'm going to turn my hand up and kind of do the condyles. I'm going to do the tibial plateau. I'm going to press on the tibial, and press a little bit. Don't just, you know, do that sort of thing. You know, compress it. The patellar ligament and the patella itself. Okay, everybody kind of go through very step by step. What I don't want people to do is I'm palpating the knee. Okay, that looks good. No, that really wasn't good. Very specific, and don't overly palpate. Just palpate the thing you want to palpate. And if you think about this, do it on the skeleton. I'm checking this, I'm checking that, I'm checking this. Very systematic. And again, going back and forth. We'll demonstrate the bulge and the balloon and the ballottement in just a minute. Let's go on to the ankle for a minute. So there's the true ankle joint and then the Achilles tendon. So basically the true ankle joint is really, if you think about, again on our skeleton, the true ankle joint is the tibio-talar joint. So right here, we want to palpate that. The subtalar joint is the one that's down here. So here's our calcaneus, here's our talus, it's that joint in there. That's important with side-to-side motion, which is called inversion and eversion. So that joint's the one that's pretty important. We used to not think it was all that important, but the true ankle joint, the one that does that, is right here. And so we want to palpate that, look at it to see if it's swollen. And so basically the idea is I'm going to be, you know, right in here. I can feel there's bone on either side. Here's our malleoli, and right in there is our ankle joint. And then the calcaneus, we're just going to kind of compress back there on the calcaneus. See if that causes any pain or difficulty. As far as the toes, and is it okay if we take your socks off?
Do this one.
Okay. All right, so if we're going to compress the metatarsal head, so this
Sorry.
is, basically I'm gonna compress this way, okay? That's great. Are you ticklish at all?
No, just
Okay.
new socks.
Oh, okay.
Black
Oh.
fibers all over
Oh,
my
no, that's fine.
They're not dirty.
I'm not worried. And then as far as palpating the metatarsal heads, basically the heads are down here. And basically if you think about, you know, it would be just like these are the heads. Okay, so we'll let you put your sock back on.
Thank you.
And so what we'll do next is we're going to do the knee, a couple components on the knee. Let's say we discovered the patient had a little effusion. So I'm going to go ahead and lay the patient down. As soon as the patient lays down, I'm going for this, right? That should be automatic reflex in PA school, just like down like that. I also like, does anybody have like, something about that big, like a shirt or a jacket or a sheet or a towel or a PA shirt? Awesome. All right. Maybe we have one that's a little bigger. Well, let's see. We'll make it work. So what I'm trying to do, I love to. Oh, okay, that's good. I love to put a little something because this is kind of wimpy. All right, nice. Okay, so it's nice to have a sheet. Okay, so the idea is, and we'll just lift you up a bit. I like to have the knee kind of in this sort of position with the kind of the thigh relaxed. It kind of, we don't want them just completely level. And are you pretty comfortable like that? So the head of the bed ever so slightly up just because it's uncomfortable to lie completely flat. So as far as, let's say, I mean, he's got that normal concavity, but let's say I suspected there was maybe some fluid in this knee. I'm going to feel on the joint line, so I know my joint line is here and here. I'm going to feel like this, and then with this hand, I'm just going to slide down, and all of a sudden, if I felt my fingers go whoop, that would be like, you know, a small effusion. Or if I did more of a medium effusion, if I did something like this, and I went over, and all of a sudden that side, I felt it bulge out. If somebody's got a huge effusion, I'm just going to be going boing, you know, and it's going to be bobbing up and down. Okay, so again, the technique is down like this, all right, or down in kind of this direction, feeling over here, or just that. Those sort of the three techniques. Okay, any questions?
Both of those?
You can do, you know, first of all, you're only going to do it if you suspect an effusion. Okay. So if you don't see any swelling or you don't think there's an effusion on a normal routine musculoskeletal exam, I'm not going to do it at all. But if there's some history or I see a little bit of edema, then I probably would do that test. And then there's some other tests that are even better. But that just gives you an idea for, yeah, they have some swelling. And then you have to determine, is the swelling in the joint, around the joint, both, or part of the synovium? And we'll get into how you do that a little bit later on.
For OSCE purposes, would you do both?
It depends on the case. Now, for you guys, for your
For our
complete,
upcoming one, that's
for
all I'm
the,
thinking
for the
about right
first
now.
one, you don't have to demonstrate that.
Okay.
I don't believe it's on that check sheet. It's not on there? Okay. But if it were an OSCE where they came in and they had knee pain, then it might be something. That's ortho in July. Okay, so is everybody pretty good on inspection, palpation? Everybody questions about that? Okay, so for range of motion, so let's go ahead and we'll take this out. So thank you very much. All right, so range of motion. It's good to do something like this. You don't want to really be telling your patient, I want you to flex, I want you to extend, I want you to laterally flex. We do want you to talk out loud during the exam, so as you do it, you're sort of talking to the patient, but you're also talking to the proctor, and you're talking to yourself and talking to what are you doing? So something that you could say is like, do what I do, and then basically we'll just kind of go through it together. So do what I do. This is flexion. Look up, that's extension. I'd like you to look one direction and then the other direction. That's lateral rotation. Try to touch your ear to your shoulder with leaving your shoulder still. That's lateral flexion. All right, so that's the neck. And again, don't fall over on myself here. Yeah, these boots, these are not very fun. Okay, so let's see here. We did all of that. As far as strength, now we're going to do strength of the sternocleidomastoid and strength of the shoulder. Again, don't memorize the numbers that are in here. They're just here to help you. So if we want to do sternocleidomastoid, we could say something like shrug against my hands. Ready to go? Okay, good. I'm going to actually put my hand on your cheek, and I want you to turn your head into my hand. Ready? Are you good? And it's testing this sternocleidomastoid. Now when I do this, same thing. I'm testing. Do y'all agree that it's that one? It's the opposite one that's popping out. It's important that you make sure they don't lean into you. So he was actually turning his head, but some people will just try to kind of lean, and that's what you don't want them to. If they're doing that, they're probably doing it because it hurts or they can't do it. So that's actually going to help you.
So they're going to be turning their head, not doing a lateral flexion?
So we did the lateral flexion already, okay? That was just for range of motion, but this is strength now. And the reason we're doing strength, that's why we organized the check sheet. We're not doing all range of motion and all strength. Where it comes up, we just finished doing range of motion, now we jumped into strength because we're here. And it just makes sense to do it now.
Right. But when they do the test, it's not strength against.
No, there is some, I usually don't do that. There is a test where we would say, chin to chest, and I would hold against him. You don't want to be doing strength on somebody's neck like that. I mean, you can really hurt somebody. So this is just meant to be like a general musculoskeletal exam, somebody who walks in and trying to pick up, joint complaints. There are some special tests later on that we will do like that, but we're not going to do strength of the neck because, having some older person trying to push against you, I mean, you can really cause a lot of problems. So we don't do that. Good question. So now we're going to do range of motion at the elbow, and basically the choices are flexion, extension, hyperextension, and so and we can actually do these together. Some of them we do together, and some of them we do unilateral. So go ahead and do this. So that was extension of the elbow, and now this. That's flexion at the elbow. And let's do this one more time. I'm looking for hyperextension. Notice he cannot hyperextend, unlike some of you who've got that extra little, roundedness, the recurvatum situation. So that would be normal. Now strength of the biceps and then strength of the triceps. Super important not to do this bilaterally. He's bigger than me. We go bilateral, I'm going to get popped in the nose, right? And so I like to do one at a time. And don't stand right in front and say, push against me, sir. Okay, so stand off to the side. And I don't want to be wimpy. I don't want to say, push, pull, okay, that's good, that's a 5. No, I want to test. I need a test. Now, I have the advantage if I put him way back. If he's way out here, you don't want to do that. You want to be way back. And try to kind of brace yourself a little bit. So, sir, push against me as hard as you can. Good. Now, pull back. I'm going to put you right here. Pull back. Pull, 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 pull. Okay, so the push, what was the push doing? Which muscle group? Triceps. And when he pulled, biceps, okay? And notice I have my other hand up here, stable. Then I'm going to switch. I'm going to do the same thing. I'm going to stand off to the side, okay? I'm going to stabilize here, and then I'd have him push, and then I'd have him pull. Okay, so real important, don't try to do 2, and don't do it just barely. Like if you're testing strength, test strength. So that's really important. Getting a workout up here. Okay, good. So the forearm, what can the forearm do? It can pronate and supinate. So I'd like for you to put your hands like this, okay, and then palm up, and then palm down, and then palm up again. Okay, so I just basically want to see, can he supinate? Can he pronate? Okay, and you can compare the two. That's helpful to do. The wrist, it can flex, and it can extend, it can radial and ulnarly deviate. So with your wrists, I'd like you to go down like this. That's flexion. Up like this. That's extension. Now back to here. Let's go out. That's ulnar deviation. And in, that's radial deviation. Now for strength of the wrist, we'll do one side at a time. What I like to do is hold the wrist. If I just said push against me, and he does, I could be getting shoulder, I could be getting elbow, but I just want wrist. So I kind of get their wrist isolated, and then I say push against me. Okay, so right there, that is, what was that? Was that extension or flexion? Extension. And then if I go this direction, okay, ready, push against me. Okay, that's flexion. And try to stay off the fingers because, in fact, if you do this, it's even better. So if you have them make a fist, push against me. Good. Push now. Good. So it was like extension, flexion. And I know that I was checking wrist and not the digits there. As far as, let's see, the digits themselves, we're going to do AB, adduction, and then strength of AB adduction. So we're going to have our fingers like this. We're going to go AB duction, AD duction, and then we're going to, now strength, I'm going to have you push out against me. So go ahead and push out. And then I'm going to put my fingers in like this, pull in, kind of squeeze my fingers, kind of like that. Yep, so you're kind of pulling in like that. So that would be AD duction, okay? And then grip strength. So basically just squeeze as hard as you can. Squeeze, 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 good. All right, grip strength. Everybody good on that? So AB, AD duction. Range of motion of the MCPs and range of motion of the PIPs. This one, I just kind of have their hands like this, and I just watch really slowly. I watch their DIPs, kind of bring your hands in. DIPs, PIPs, MCPs all the way in. and now all the way back out. And I'm just looking for one particular digit to be an outlier. But basically, if you do it slow, you can see their DIPs go, then you can see their PIPs go, then you see their MCPs go. If you do it too fast, you're going to miss it. But kind of go slow so you can kind of look at each joint with regard to range of motion. Okay, the hip. We like to do the hip strength seated. You don't want somebody standing up and pushing against, they could fall over. So if you think about it, if I want to check hip strength, and again, notice how I'm going to stand off to the side, because notoriously, if I do this, the patient wants to kick out. So I always show them, first of all, I stand off to the side, then I say, I want you to take your leg, and I want you to do that. Ready, go. Okay, so I'm checking flexion. Now, I'm going to have you like this, kind of pull down, pull, pull, pull. Okay, so that was extension. So I was checking strength, and that was extension. And you don't want to really do both sides at a time, right? That would be really hard on somebody's back. Then, if I kind of put my hands like this and I say push out to the wall, ready, go, that would be abduction and pull in, and that would be adduction. Y'all see that I'm testing. Those you do simultaneously, because it's easier for patients to do that rather than just one side versus the other. That makes sense? AB adduction. I'm getting old. Whew, see what happens? Golly. Okay, knee. Strength of the knee. So again, if you can sit down and stay out the way. Don't stand right in front of them. So this, I don't want to be like testing the knee way up here. I want to have the advantage. So I go down the furthest I can, stand off to the side. I kind of stabilize on the table, and I say, go ahead and push out against me. Ready, go. Okay. Pull back. Ready, go. All right. So when he was pushing this way, what was that? Extension or flexion?
Extension.
Extension. When he was pulling back, it was flexion. And I would do that on the other side as well. So that's the knee. The ankle, we can do it a couple of ways. First, we're going to do range of motion. So point your toes down, pull them up to the sky. Okay, so that was basically pointing is plantar flexion. Up to the sky is dorsiflexion. Then you can do, we're going to do strength next. So again, strength can be a couple of ways. I like to do it, so I just kind of hold their ankle and I say, press against my hand, step on the gas, good. So that was what? Plantar flexion. Toes to your nose, ready, go. All right, that's dorsiflexion. And then I would compare. Now it's hard for patients to invert and evert. So kind of, let me just kind of demonstrate. So when you point your toes in like that, can you go ahead and put your toes in that position? So that's called inversion, okay? And then if you take your toe and go out there, that's eversion. So it's really hard for patients to just press against you. So what I do is I put them in the position I want. I put this patient in like eversion, so hold your foot like that. Don't let me move you. Okay, actually, sorry. Let me put you in this position. Now, don't let me move you. Okay, I'm testing. He's in inversion, and I'm pressing against him. Let's do this one again. Eversion. Don't let me move you. Okay, so I'm pushing the opposite way. Rather than saying, push against me, I put him where I want, and I say, hold it there. Don't let me move you. So it's slightly a little bit different. And then you could do, if you wanted to, instead of pushing down, you could have the patient, if you don't mind standing up for a moment, can you walk on your tippy toes like this? Okay, so that's plantar flexion. He can support his own weight. How about, can you go on your heels and walk on your heels? That's dorsiflexion. He can actually support his own weight without sort of dropping down. That's equivalent to pushing against you. So you can do it that way as well. And then the toes, basically just ask them to curl their toes and put their toes back out. For some of you, you have really great, your toes can actually bend down and do all this stuff. My toes, pretty much, if you said, flex your toes, there they are. Extend your toes, there they are. Yeah, nobody does. But just know there's some variability in toes, okay? And I know some of you can write notes and stuff, art and everything. But just know, again, the toes are not, we don't care so much about toes. Okay, moving on to the greater trochanter. So basically, this is where we're going to lie our patient down again. So we'll go ahead and lie him down. We'll immediately got that reflex. So this is where we're going to take the patient passively, and we're going to abduct. And actually, his anterior superior iliac spine, which is this right here, anterior superior iliac spine, it's the thing that points out the most. You can kind of feel it right there, right there. And then we're gonna just passively abduct until about right like that. So that's abduction, and then we bring back, that's adduction, okay? And then I'd go over to the opposite side. So just know that if I'm testing the right leg, I'm on the right side, I'm holding the pelvis stable, kind of holding it down from moving, and I'll pull them out into abduction and then back, and then I'll go around the other way. As far as internal and external rotation of the femur, I put the patient at 90-90, okay? So he's 90 degrees here, 90 degrees here. And if I kind of swing that way, what's his femur doing? Internal. And if I take his like that, external. Okay, so that's external and that's internal. And you want to keep it in the plane of the body. So don't abduct them like that. Keep them in the plane of the body. And then basically I kind of hold them as if like the joint space here. So that's going to be internal and external rotation. Okay, everybody got that one? And the greater trochanter is if you were to lie on your side, and have you lie that direction, the bone, whatever is sticking out, is your greater trochanter. So basically, this thing right here, that's your greater trochanter. So it doesn't matter how much they have, you can always find it. It's right there. So that's greater trochanter. So you just want to know its location and does it hurt. Okay, now we'll go ahead and let you sit up again. Moving on to shoulder this time. All right, I need a fan.
It's getting hot in here.
Whew, is it? Is it just me? Okay, so we can do the combo thing. So the combo thing is, can you take your hands and go behind your head like this? Okay, that is combining abduction and external rotation. Now, can you take your hands and go like this with your thumbs? That is combining adduction and internal rotation, and he can do that. So if I was just screening, you could do that, but what happens if he can't do one of them? Let's say I ask him to do this and he can't. Well, is it because he can't abduct or he can't externally rotate? So you want to know how to separate them out, and so we'll actually do that. So as far as the shoulder, so again, we can do it standing or you can do it seated. So let's take your hands up like this as far as you can. That's flexion, and then back down, all the way down and back. Good. And now out to the side, that's abduction and adduction. Come across the front. Good. Then palms up like this and out to the side. That's our horizontal AB and adduction. Okay, everybody good with that? And then if we wanted to do internal and external rotation, I like this one because people understand it. So let's put our shoulders like this. Field goal, 3 points. Okay, that's external rotation. Back to this position. Can you go like this? All right, so basically that's internal rotation. Okay, so here was neutral, there was external rotation, here's neutral, here's internal rotation. We could also do it at the side. Let's say I put his arm like this, and that's internal and external rotation. So external is like that, internal is like that. So you can actually do that. Just make sure they're not abducting because they can cheat and get a little bit more. So, but I do like the field goal method because you can really see if somebody can't externally rotate when you actually do that. Okay, shoulder strength. All right, so as far as the shoulder strength, we said that you don't want to do, for instance, this, okay? Because how do I know I'm not getting elbow? So if you take it and put the elbow like that, and then basically I'm going to stand kind of behind, let's see, yeah, I don't know how, can you like maybe turn that way a little bit? Okay, so if I put him at this position, let's do this one first. So why don't you, I want you to take your arm and go backward, all right? Not quite yet, so ready, go. All right, so that's extension. Now I want you to take your arm and kind of go forward like that. Not quite yet, hang on. All right, ready, go. Okay, that's flexion, so that was flexion. Now if I say push out against me, that's abduction. Pull in against me, that's adduction. Okay, so basically this way, this way, this way, and this way, without having to do, if it looks awkward, it's probably something weird that you're doing. So try to kind of keep it pretty straightforward. As far as horizontal AB and adduction, that's where you're out to the horizon like this. So go ahead and put your hands out. So if you're out like this, oh, you're doing great. So he can't cheat, right? Because his elbow can't cheat. So make your arms go, not quite yet. Hang on 1 second. Ready, go, go, okay. And now palms up and kind of push in towards me. Okay, so you could do horizontal that way if you needed to, just because the elbow's not going to be in our way. Okay, as far as trunk, so let's have you go ahead and have stand up, please. And I'm going to stand behind you, and I'd just like for you to try to touch your toes, and I'm just going to hold on to your hips, okay? So we'll have you kind of turn that direction. So go ahead and touch your toes. I'm sort of looking at his back. Sorry. All right, you can go ahead and come back up. So that was flexion at the trunk. Now, trying to keep your pelvis steady, can you just kind of lean back without like moving your legs? So lean back. So that's extension. So you can see not much. Now, can you rotate to the right? You're doing great. Can you rotate and try to go to the right while you keep everything still here? Okay, that's rotation, and in the other direction. Now, can you lean to the right? There you go. All right, and to the left. Okay, and you notice it only counts if you're holding on, because otherwise people can do all this kind of stuff and you think you're getting a lot of stuff, but you really want to make sure you're really doing what you think you're doing. As far as range of motion of the hip, you can do this standing, so you can have the patient just kind of touch the exam table and just lift their each respective, okay, so there's that, hip flexion, and then even just the fact that he goes back down slowly, that's really extension. We're not going to ask him to do extension because really you're not really getting good extension. If you really needed to do extension, we'd lay him down and have him, just for fun, let's go ahead and have you lay on your belly, just so we can demonstrate, and we probably would not do this to a patient, is I'm going to kind of press down on your pelvis, and I just want you to kind of lift your leg off the table. Ready, go. Actually.
Oh, you time.
So that's a perfect point. Patients do exactly what you say. So basically, I did say lift your leg, so that's a perfect thing. So go ahead and I'm gonna actually bend your leg like this. Can you go ahead and lift this part of your leg off the table? Okay, so not much. Okay, so we wouldn't do that, but I just want to thank you. We'll let you know. You can see that extension, true extension of the hip is really that's it's really more just can you go back down and control it. Let's see, we did hip, range of motion up the knee. Okay, so basically just straighten your leg, so that's extension. And then this is tough to do. I actually like to do this standing, so if we have to make you stand up again. So, and the reason because if I had him flex, the table's going to be in the way, but if you kind of face these folks here, and if you kind of like straighten all the way out, and then all the way back, that's extension. I'm sorry, flexion. So flexion and extension of the lower extremity. And always make sure your patient kind of can hold on and be steady. And then the ankle we've already kind of talked about, where you either walk on your heels or walk on your toes. I know that's kind of quick. Wow, we have a lot of extra time. So questions about the exam?